The kind of research work that we are doing is called the investigator-initiated research. That means me as a doctor or a clinician, always the disturbing element was, why is it that we are not able to do what we are expected to do? It works in a small setting, in a private setting, in an educated population, in an economically sound population, which means in our own ivory towers in the metros. But the same thing cannot and does not work in large parts of this great country. So that was the start or the trigger factor for doing something called the operational research. That means we know what the country's problems are. We know the answers to those problems, but we have to get off the ground to implement those solutions in the Indian context, because some things with the education, economic, cultural background, as well as the traveling distance, is so very unique to the nooks and corners of our country that in a way we need some simple solution which are feasible, logistically possible and doable in the entire length and breadth of the country. So the first small research work that we took up was with respect to the issues of anemia or low hemoglobin. Many of our women are pale and they get into pregnancy with the same state, and when they deliver, oftentimes they lose their lives only because of this simple, correctable problem such as anemia. And when we figured out that, yes, the government has launched a initiative of giving the iron tablets to correct this problem and improve this situation, but last 30 years, nothing really has come out of it. And then when we saw what are the recommendations in the West, we recognized that the Western world has only 4% of their pregnant women as anemic, whereas in India, there are 75 to 90% of our women are anemic. So we have a larger population who are at much more risk. So what they recommend cannot hold good in the Indian context. And many times our women in pregnancy do not take the kind of tablets that the government gives them, so the problem remains as a problem. But then we said there has to be a solution, and the solution was in the form of a new type of injectable iron, which is FDA approved and recommended for use. But of course, the West will use it very less because they only need it for those many women. Whereas in the country context, yes, we need to use it for a large number of women before they deliver because we have to save lives. So that was the startup project of the anemia research, and we are happy that the clinicians have taken to the use of this, and usage of this was only 2% in the entire country, but now it has scaled up to about 90% of the practitioners are using this as a quick method to correct the problem of anemia, and the government has taken this into the policy as well. The next big problem, having spoken about A for anemia, now I'll speak about B for building contraceptive choices. So the population explosion is a huge problem in the country, and we've tried variety of contraceptive methods to contain the problem, but unfortunately, again, only 2 to 5% of the women who need it do use it. So now the government is giving financial incentives to deliver in an institution. So our institutional deliveries have scaled up from 20%, now 80% of our women are coming to the hospitals and delivery. So every single woman who delivers in a hospital should not move out of the hospital unless she has a contraceptive advice in place, or even better, that she has a contraceptive device in place. So there came the revisiting of one of the initiatives called the post-placental intrauterine contraceptive device. So we did a lot of research work on that, presented it to the government, worked with some NGOs, and now the government has taken it up as a national program. And again, the flaw is in the implementation. We know what to do. We could do a lot better than we are already doing, but on a positive note, I must say that from 5%, the usage has scaled up to 20% of our women in the reproductive age, which is in itself a significant leap forward. The third is the cancer cervix related, the new vaccine, the HPV vaccine, which has come into the market. Yes, many women know that it is safe. For example, 85% of our women know it is very safe, but not even 8% have taken the vaccine. There is some gap in the understanding of how to get them to take the vaccine. So again, studying the knowledge, attitudes and practices on this was a part of the research, because unless you build the data gap, you cannot build the solution gap. So with that vision, we field tested the attitudes of why women are not taking it, and worked our way around the communications to make them reach the correct messages. And now the vaccination coverage, at least in the metros and in the affordable population, is slowly, steadily improving. And the digital media is one of the easiest ways where we can reach maximum number of masses of women in the country. So we are completely exploiting that as well. D is the diabetes, which is again a mind-boggling problem in this country, because if you see the adult diabetes or type 2 diabetes, we are 70 million Indians with type 2 diabetes, and half of them are women. When we say there are 35 million women who are type 2 diabetes, half of these would have been pregnant a couple of years ago, and in pregnancy they would have had high levels of sugar, and that has been a forerunner, and as a continuum, 5 to 10 years after delivery, they become the adult diabetes. So the large population, which is in India now labeled as a type 2 diabetic, could have been contained or controlled by doing something at the level of the pregnancy care. So then started the initiative of again tapping from the practitioners what they're currently doing, why they're not able to do what they're expected to do, and how to devise some simple tests, some evidence-based initiatives which can make this work for us in our country, and thereby a single step test and a non-fasting test which was introduced. That was again researched, published, and whether instead of drawing the regular blood sample from the veins, can they just use a simple point of care AccuCheck or a device which any women can use in their own homes. Will that work for our country was another thought, and that was another significant area of research, and we have percolated this message to the practitioners in the entire country, and also brought in a certification course in collaboration with DIPSI, which is the Diabetes in India Study Group, and the WDF, that is World Diabetic Foundation. Both of them and the FOGSI together initiated a course on diabetes management in pregnancy, because no practitioner would be spared. They will have to learn more on how to handle these women, because the numbers are escalating and their understanding needs to be broader and deeper. So that is again another large area. So we have to generate demand from the women, because women should know that this test is needed for every single pregnant woman, and we have to strengthen the supply side as well, because if more and more women are coming and seeking this test, then all frontline healthcare providers should be able to understand and offer this test. And the hassle doesn't stop there, because if these many numbers are diagnosed, then what do you do with them? How do you manage them? That is the next part of the challenge. So we have to build the capacity of the healthcare workers in the entire country, and the investment of our time and efforts and energies now on doing this massive exercise is certainly going to go a long way in tapping and mapping every single pregnancy diabetes in the country, giving her the long-term care which is really much needed, because if she is diagnosed to have diabetes in pregnancy, be sure to track her every single year with her sugar testing, so that the next 5 to 10 years, if the sugars are coming in again, the lifestyle, the diet and exercise alone can control a large number of them and prevent the morbid complications related to their heart and the cardiovascular system and other metabolic disorders that she's likely to have. So it's a continuum of things. And I've just said about the ABCDE, the A for anemia control, B for building contraceptive choices, C is cancer cervix, D diabetes, and E also means etc. But in our context, at the moment, it means emergency obstetric care. So many women are coming to the institutions to deliver, but unless there are people who can provide that emergency care and save lives, instead of dying at home, she is dying in the institution. It translates into that. So emergency obstetric care to save lives is yet another important aspect of how to train with the skill drills, because knowledge base is enormous, but when it comes to actually doing the actions on the ground and handling an emergency, in the quickest possible time, in the best possible manner to save lives. That's what is the gap that we are trying to bridge. So overall, it's very challenging to tackle a variety of problems in the country, but at the same time, I think we have a wonderful opportunity to innovate different methods for implementation, see the impact of this, and ensure a healthy generation next.
Dr. Hema, since you are the ambassador of FOGSI for FIGO in India, what are your thoughts on what kind of changes or new innovations you would like to bring into the field of medication in India during your term of 2 years?
When we always say at the international level, this is a big organization, but what we recognize is that through these big organizations, we have to get back what we need in our country, and whatever works in India can be a role model for the entire South Asia and Africa. So that will be our biggest contribution from the Indian contingent, because we can train people well, we are skilled enough, and we have moved far ahead in our innovative methodologies of sorting our own problems out. So all of these, not only that we strengthen in our own country, but also help the population in the South Asian and the African countries through the bigger umbrella or the banner of FIGO. So at the moment, I'm involved with two main initiatives from the FIGO. One is the FIGO working group on hyperglycemia in pregnancy, that is high sugars in pregnancy. So that is the position of the vice chair of the working group. So I'm heading the subgroup of capacity building, because the passion and vision is to train as many people as possible to provide the care out there, because so many women would need that care. And capacity building is a difficult exercise because it also has to bring about a behavior change, both from the women and the healthcare providers. So that is one of the diabetes related is one of the major initiatives that we are doing through FIGO. And another FIGO initiative is the FOGSI FIGO PPIUCD project, which is PPIUCD expands as post-placental intrauterine contraceptive device. So that is one of the major, it's revisiting the methodology that we already knew. So every innovation need not be totally new. It's a new way of doing the same thing, which has to prove itself that it's more efficacious, more simple, and more doable in our country. So the FOGSI FIGO PPIUCD initiative has started in 6 centers, and we are expanding it to 12 more centers. So the percentage of women now moving out of the institutions after their delivery will get one method of contraception or the other to space the next pregnancy or to limit the family. So these are the two major initiatives, but there are several other things where Indian mass trainers are going to the neighboring areas to train people in the regions that I just mentioned. So the scope is immense, but I think we should do one step at a time, remain focused on the simplest thing which will have the major impact. So that is where we are moving.
Thank you, Doctor. It was a pleasure speaking to you.
Thank you very much. Namaskar.